Hi guys, it's me Jimmy and welcome back to my channel. So in this video, I'll be showing you how to do a tracheostomy. Tracheostomy refers to the creation of a communication between the trachea and the overlying skin. And for this video, we will be focusing on the open surgical technique. There are various reasons why we perform tracheostomy. It can be used to bypass an airway obstruction, providing respiratory support by delivering oxygen easier to the lungs, performing pulmonary hygiene by cleaning and removing airway secretions, eliminate dead space, and even treatment of obstructive sleep apnea. Before performing tracheostomy, one must have a thorough preoperative evaluation. This includes the level of obstruction, the anatomy of the neck, the presence of coagulopathy, the cardiorespiratory status, any deviation of the cervical trachea, and laryngeal cancer. Materials needed: tracheostomy tube, Cooper's scissors, scalpel, mosquito forceps, muscle retractors, and tissue tweezers. So are you ready? Let's begin!
Tracheostomy is best done in the operating room with good lighting, instrumentation, suction, diathermy, and assistance. Place the patient in a supine position with the neck extended by a pillow or a bag placed under the shoulders. This is done to deliver the trachea out of the thorax and to give adequate access to the cervical trachea. Sterilize the skin of the anterior neck and the chest. Unless the patient can be safely intubated or the patient can be ventilated with a mask, a tracheostomy should be done under local anesthesia. Drape the neck. If the tracheostomy is done under local anesthesia, the face can be uncovered. The tracheostomy is created below the first tracheal ring to avoid subglottic stenosis as a result of scarring. Run your finger up the midline of the neck, starting inferiorly at the sternal notch. The first prominence encountered is the thyroid isthmus, followed by the cricoid. Make a horizontal incision 2 cm above the sternal notch. Extend the incision through the skin, subcutaneous tissue, and the platysma. Take care not to transect the anterior jugular veins, which are just superficial to the strap muscles within the cervical fascia. They can be preserved and retracted laterally. Dissect the trachea by parting the tissues with scissors. Remain strictly in the midline in a vertical plane to avoid injury to the inferior thyroid veins. You can now identify the midline cervical fascial plane between the sternal hyoid muscles. Divide this intermuscular plane by spreading with a pair of scissors. Repeat this maneuver to separate them and retract the muscles laterally. The trachea and cricoid can now be palpated. Sometimes, you may encounter the thyroid isthmus that overlies the second and third tracheal rings. If encountered, retract the isthmus superiorly to expose the trachea. To expose the infrathyroid trachea, carefully part the overlying pretracheal fascia with a pair of scissors. Take care not to tear the inferior thyroid veins. Ensure that the cervical field is completely dry before proceeding, as it is difficult to achieve hemostasis once tracheostomy tube has been inserted. Should there be doubt whether it's a trachea or carotid artery, aspirating air with a needle attached to a syringe will confirm its location. Create an inferiorly placed flap raised from the anterior wall of the third and fourth tracheal rings. This is the safest tracheostomy in adults. After the flap is created, a silk traction suture is passed through this anterior tracheal flap and is loosely secured to the skin. Assess the size of the trachea and select the largest cuff tracheostomy tube that can comfortably fit the tracheal wound. Inject air to the inflatable cuff of the tracheostomy tube to test its integrity. Insert the tracheostomy tube under direct vision while applying traction to the suture attached to the tracheal flap. Ensure that the tube has been inserted into the tracheal lumen and not in the false passage in the paratracheal soft tissues. Remove the obturator and insert the inner cannula. Ventilate while confirming for the correct placement of the tube within the trachea by checking the expired PCO2, chest movement, and listening to the breath sounds. Secure the tracheostomy tube by threading tapes through the holes in the flanges of the tracheostomy tube. Pass them around the neck and ensure you tie them with the neck flexed. The tie should be tight enough to admit no more than a single finger under the tape. The tracheostomy tube is sutured through the suprastomal skin for the first few days until there is maturation of the tracheocutaneous shaft. The sutures can then be removed, after which only traditional tracheostomy tapes are used.
It's also important to take note of the possible complications of tracheostomy. There can be immediate or late complications. Immediate complications include bleeding, tracheal tube obstruction, pneumomediastinum, pneumothorax, loss of airway, tracheal ring fracture, paratracheal placement of tracheostomy tube, injury to the thyroid, and cardiac or respiratory decompensation. Late complications include infections, granulation tissue formation, tracheal tube displacement or malposition, cuff leak, tracheal stenosis, tracheoesophageal fistula, and tracheovascular fistula. So that's it for this video. I hope you guys learned a thing or two about tracheostomy. If you liked it, make sure to like, share, and subscribe. And that's it. I'm Jimmy, and see you on the next one. Bye!